In today's video lecture, we will be talking about the gastrointestinal system, GI system, and some alterations, specifically in the upper tract. Gonna do a quick anatomy review of the GI system. So it's basically a tract that extends from the mouth to the anus. Pretty much has the same structure throughout. You have the hollow portion, which is your lumen. You then have a muscular layer, and then you have a bunch of epithelial. Let's all say it together, epithelial. Epithelial cells on the surface. Main functions of the GI tract include transportation, digestion, and absorption of food. The mucosal integrity of the GI tract and the functioning of the accessory organs are pretty vital in maintaining your health. So components of the GI system include the mouth, esophagus, stomach, small intestine, large intestine, blah, 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 blah. But we're not worried about those, right? Right now, because we're focusing on the upper. So, secretion of hydrochloric acid and digestive enzymes happen, especially with starches. The stomach pH is about 2, extremely acid, and may leak into the system. Let's see, digestion is the mechanical mastication and chemical reactions of digestive enzymes. Hydrochloric acid is secreted by the glands of the stomach. Pepsin, P-E-P-S-I-N, P-E-P-S-I-N, is important for the digestion of proteins. And whatever is absorbed in the GI tract is released into the blood supply. And then motility of foods is pretty much the movement via esophagus to peristalsis. And then, of course, you have the elimination of foods. That's like my side case of a poop emoji. Continuing on with our basic anatomy review. So we got our salivary enzymes. Those begin the breakdown of CHO, or other known as carbohydrates. Is butter a carb? Preparatory is where the food softens to form a bolus, and then the tongue moves the bolus to the back of the tongue, back of the throat. Okay, that was continuing on with our anatomy review. So in our mouth, we have salivary enzymes, mucin and amylase. Amylase is pretty much the enzyme that begins the breakdown of carbs. And then we're going to go into the 4 phases. Preparatory phase is where the food softens to form a bolus, that nice little ball. And then the tongue moves the bolus to the back of the throat. Oral phase presses the bolus against the hard palate to trigger swallowing. Pharyngeal phase seals the nasal cavity to inhibit respirations. And then this allows the esophagus to open. Once we get into the esophageal phase, that's where peristalsis starts. So your bolus is moving down your esophagus via peristalsis all the way down to your stomach. Okay, quick review on the esophagus. Pretty much it's a canal that is approximately 10 inches long. The upper esophageal sphincter is closed at rest to prevent air from entering the esophagus. And then the lower esophageal sphincter belongs to the gastroesophageal junction. Esophageal junction. And when that is at rest, it remains closed to prevent reflux, or also known as GERD. One of the topics that we will be talking about. And the cardiac sphincter is the open enclosure that allows food to enter the stomach. All right, for our region of the stomach. If you remember, our lovely stomach is covered in rugae folds. These lovely guys and waves. Pretty much comprises smooth muscle for motility. The cardia is the narrow opening that holds the cardiac sphincter. So in the previous slide, that is the port of entry for food into the stomach. Fundus. Let's see. That is here. The body of the stomach is the largest. And then the antrum is the lower part of the stomach that holds the broken down food until it is released into the smaller intestine. Alright, since we had different phases in the mouth, we also had different phases in the stomach. Cephalic phase, that pretty much occurs when someone sees, smells, or tastes food. So like every time that I pass by McDonald's, because I totally love their fries and I smell it, I need to go buy a large size immediately. The gastric phase occurs in the antrum. Pepsin digests proteins. So the bicarb protects the stomach wall from acid. Let me note that here. So we have, again, pepsin digests proteins. You have your bicarb. Does anybody know the elemental structure of bicarb? It's actually HCO3. So that protects the lining, protects the stomach wall from acid. Periodic cells are the ones that secrete hydrochloric acid, and that absorbs B12. So does anybody know the condition where you cannot or unable to absorb B12? This will be most likely discussed in your next semester. So if you cannot absorb B12, it is pernicious anemia. And pretty much what happens is, or your presentation is, you're pretty much weak and tired. Symptoms include a red, beefy tongue. That is also one of the clinical presentations. So here's your tongue, and it's super red. Not that lovely pink, but red. Interventions for pernicious anemia are B12 injections, usually weekly until levels normalize. And then, I forgot to touch on chief cells. So those pretty much activate pepsin, the breakdown enzyme. I didn't insert my first NG tube on a real patient until maybe 6 months after I graduated and passed the boards. Surprisingly, it wasn't that bad. It actually felt satisfying once, the suction was working and then the patient's gastric contents are coming out. So satisfaction for me that I actually placed it in, and satisfaction that the patient started feeling relief. So the NG tube is that lovely tube that carries food or medication to the stomach. It could be also used to suction obstructed gastric contents. So basic care and maintenance of the NG tube. Number 1, patency. Can't enter the tube if there's obstruction. Always check for patency, obstructions, polyps, deviated septum, all that good stuff. Measurement of the NG tube include the tip of the nose to ear lobe to the xiphoid process. If you were to say sternum, not a good answer. Please say xiphoid process. Best verification of placement is obtained by a chest x-ray. It has been, based on evidence-based practice, that we no longer should auscultate for placement, meaning do not inject air into the NG tube and auscultate in the stomach to verify placement. Extremely important. Pretty much flush the NG tube every 4 hours to remain patent. And the proper administration of medication should always be flush, flush, which is the same concept as your IV pushes. Flush, flush. When you want to remove the NG tube, please instruct your patient to hold their breath and pretty much hold it while removing the NG tube. If for some reason the tube becomes clogged, we are to administer 10 mLs of warm, sterile water. So we got a clogged tube. We're going to administer 10 mLs of warm to break all those little chunks of food off, or medications. We want to pretty much dissolve the bolus that's stuck in there. And then we want to gently pulsate while we are instilling the warm, sterile water. If the blockage does not clear, still clogged, we're going to clamp the tube about 5 to 15 minutes. Of course, that's after you instill the warm water so it can soften the clog. So we're going to clamp, warm water to soften up the clog. I've heard stories that nurses back in the day administer Coke or Pepsi to dissolve a clog, but I have never seen it in real life. All right, now we're done with the anatomy part. When you're admitting your patients, we are going to gather subjective data. So, in the family history, you can ask your patients if they have any history of GI disorders, cancer, past medical history, diarrhea, constipation. If they're old enough, have they had any colonoscopy screenings, both male and female? There are guidelines for that. Please look that up. Changes in weight or appetite, dysphagia, food intolerance. Can they do a 24-hour food recall? Do they have abdominal pain? Is it before or after eating? Which quadrant? Is nausea, vomiting, and diarrhea involved? Bloating, gas. Quick tidbit: guidelines for colorectal screening begins at age 50 years of age, and then after that, every 10 years, unless something was found first one, then they do additional screening. But colorectal cancer screening every 10 years. I like to share a story about that. My father was diagnosed with cancer in December. There were two primary sites that were found, one in the colon and one in the left kidney. The only reason why we found out about the cancer was he was in a car accident and they did a CT of the abdomen. They pretty much found the masses. But what was really disheartening is because he did not have any symptoms. If anyone knows, kidney cancer, renal cell carcinoma is pretty much a silent killer. Most patients don't really have any symptoms until it's way already progressed. So my father got the colon mass removed, so it's been resectioned, and then as far as the left kidney, that has been removed, so a nephrectomy. So far he's doing okay. He's only on oral chemo medications, but even with oral medications, it takes quite a toll on a patient. Of course, you go with the ups and downs. He's tired all the time. He gets really bad side effects from the medications, blisters on the hands and feet, but all we gotta do is push forward. Enough with the touchy-feely story. Objective. So this is information or data collection that is tangible. Inspection of the upper GI tract. You're looking for skin, symmetry, rashes, lesions, or even scars from past surgical procedures. Can you see visible peristalsis? Now, if you do see little wave-likes in here, probably most likely found in the left lower quadrant, that indicates that there is an obstruction. Auscultation, normal active is less than 15 seconds. And then you must listen for a full 2 to 3 minutes to determine if the sounds are absolutely absent. So ileus versus borborygmus. Ileus is a condition where there's a lack of intestinal activity. So this could lead to, if you don't have intestinal activity, well, everything's gonna hang out there, and that's going to rupture the bowel wall. Hyperactivity happens when diarrhea or after eating, also known as borborygmus. And so let's just say that 1 hour ago, you auscultated your patient and they have hyperactive bowel sounds. Check on the patient 15 minutes later because he's feeling excruciating pain. And now there are no bowel sounds, absent of bowel sounds. What could that indicate? Pretty much the rupture of intestines or the strangulation of bowel. Bruise, also known as swishes, indicates a narrowing of the arteries. So if you can see my lovely picture here, this is a AAA. Alarm, alarm, alarm. Abdominal aortic aneurysm. So, for patients who suffer the rupture of a AAA before hospital arrival, the prognosis is pretty much guarded. So, more than 50% do not survive once they reach the emergency department. For those who do, the survival rate drops by 1% per minute. But of course, it depends. Is the patient already in severe shock? Were they received timely? And which surgical intervention or person is there to perform the repair? So what can we do to prevent it? Or let's say somebody is living with an aneurysm. It's pretty much focusing on heart health. Pretty much watching what you eat, exercising, and avoiding other cardiovascular risk factors like smoking. Most common cause? Not known, but atherosclerosis is thought to play an important role. So how do we fix it? Open repair. Basically, the doctor makes a large incision in the abdomen to expose the aorta. Once that's open, then he can repair it, or they can do a endovascular aneurysm repair, an EVAR, which is the EVAR, most minimally invasive option. So instead of making this large incision, the doctor makes a small incision in the groin. He or she will insert the special instruments through a catheter in the artery into the groin and thread up to the aneurysm. At that point, the doctor will place a stent and graft to support the aneurysm. One way that you can elicit a hernia is having the patient lie flat if they can tolerate it, and ask them to raise their head. If the hernia is, superficial enough, you'll be able to see the bump or lump or hernia, as you could say. Special techniques. You have your Rovsing to rule out appendicitis. It is the rebound tenderness upon palpation to the left lower quadrant. And then you have Murphy. Murphy sign is right upper quadrant pain on inspiration to rule out cholecystitis. I went ahead and put our lovely picture of the C. diff bacteria. It smells great. So lab tests you can perform: CBC. Your H&H can indicate anemia if they have acute GI bleed. Serum amylase and lipase, if they are elevated, could be used to rule out pancreatitis. Let's see here. A decreased calcium indicates malabsorption of minerals. If your potassium is decreased, potassium is decreased with vomiting and diarrhea. We could take a stool sample, a cold blood, for a GI bleed, over a parasite infection, or a stool sample could be used for to see if there's fecal fat, indicating Crohn's disease. Lab value specifically for cholecystitis would be your T-bili if it's elevated. Diagnostic testing. So a small bowel series uses barium to determine the cause for difficulty swallowing, if the patient has abdominal pain, or unexplained vomiting. Small bowels, FT is used to diagnose tumors, obstruction, or Crohn's disease. And with an EGD, esophagogastroduodenoscopy, can determine 5 conditions. We could determine GERD, if there's damage to the lining of the esophagus. You have Barrett's esophagus, which is imminent for cancer. We could find ulcers such as from gastritis. We can find esophageal varices and stricture. And the process for any GI testing patient pretty much have to be MPO for at least 8 hours to get rid of stool, gas, and free air. After an EGD, a gag reflex may not return 1 to 2 hours after testing, so it's common practice to keep your patient MPO after the procedure. And you should perform, which one should you perform first? A lower GI diagnostic test before GI, upper GI, or vice versa? Let me know. All right, our favorite part. GI drug therapy. So let's see here. Common GI drug therapy inhibit gastric acid secretion, accelerate gastric emptying, or it can protect the gastric mucosa. So inhibit secretion, accelerate emptying, and protect. Antacids elevate the pH to prevent heartburn, and it should be taken 2 hours after meals. And the way they do that is they produce neutral salts. However, you should use caution with renal patients. Let's see. It must be taken 1 hour after all other medications. Histamine receptor agonist, you're dying. D-I-N-E. Ranitidine, famotidine. Those inhibit acid secretions. It is the first choice of drug therapy. PPIs decrease gastric acid secretion by 90%, and they end in zoles. Omeprazole, pantoprazole. However, these can increase the risk of serious adverse effects such as pneumonia, acid rebound, and even C. diff. And you do not want to abruptly stop the use of PPIs because of rebound hypersecretion. Prokinetics. They empty and promote peristalsis. A common one would be Reglan. This works by blocking dopamine receptors, and it should be given before meals and bedtime. Your cytoprotective agents or barriers, let's see, such as like Carafate. They create a protective barrier of the gut wall for up to 6 hours, and they're only approved if gastric ulcers are caused by long-term NSAID therapy. Let's see, I'm going to talk about Cytotec. So Cytotec is a pregnancy category X. It must be given on an empty stomach, not within 1 hour of eating or taking antacids. Let's see. What can we do if the patient cannot tolerate capsules? What happens if the patient protests to the capsule if it is too big? They can open the capsule, sprinkle content onto basic nutrition such as applesauce, but you do not crush the contents of the capsule. Antiemetics. I don't want to barf. Stop my nausea and vomiting. Let's see. Phenothiazines block dopamine receptors that cause sedating effects and extrapyramidal reactions. They also block cholinergic, alpha adrenergic, and histamine receptors. Some of the population use cannabinoids. And you should use in caution because it works on the CNS associated with cancer chemotherapy. Marinol only contains cannabinoid and sesame oil. And so what happens during chemotherapy causes the release of serotonin. And with the next antiemetic, the 5-HT3 receptors, those are antagonists against, or they block serotonin. But what could also happen is that if the HT3 receptors are given IV, they could cause fatal dysarrhythmias. Zofran is a pregnancy category B. So in 2013, the FDA issued a warning the use of Zofran in early pregnancy because it could cause congenital cardiac malformations. So today's guidelines, if you are in the pregnant population, alternatives include Diclogest or Bone Gesta, but these guys are extremely expensive, so I would try other ways to reduce your nausea and vomiting if needed. When I was pregnant, I had a lot of, I did vomit, but I always felt, nauseous. So I didn't want to use any medications. I went ahead and got these C-bands. I don't know if you guys know about the C-bands. They're pretty much bracelets that have a little nodule there that causes a pressure point in my wrist. Those worked pretty well. Let's see, scopolamine. These transdermal scopolamine is a belladonna alkaloid anticholinergic. Most common side effect is dry mouth, and scopolamine is highly permeable. Therefore, the oral administration increases adverse effects. So the only time I've ever seen scopolamine is behind the ear, a nice little ear right here, and my patch was not mine, but I've seen patients and they just have a nice little square patch right behind it. Now we're gonna get to the alterations in the upper GI. We're gonna start off with GERD. So gastroesophageal reflux disease is a digestive disorder that affects the lower esophageal sphincter, the LES. That is the ring of muscle between the esophagus and stomach. So who suffers from this? Many people, including pregnancy, like they suffer from heartburn and indigestion caused by GERD. Doctors also believe that some people suffer from GERD due to a condition called hiatal hernia. However, in most cases, GERD can be relieved through diet and lifestyle changes. But who's going to want to do that? But then if they can't change their lifestyle, then they're going to have to turn to medications or surgery. So within GERD, your oral mucosa esophageal mucosa is pretty much irritated by all the acids that's coming back up. Gastric and duodenal contents. So what happens is that once the LES or the lower esophageal sphincter relaxes at the wrong time, it can allow those contents to flow back into the esophagus. So clinical presentation is pain to 1 to 2 hours after eating. After eating, pain. Vomit, non-digested food. Non-digested food, aka heartburn. Patient can say that there is a burning sensation in wave-likes and while bending over. So wave-like burning. Could have a chronic cough at night and belching. The only way we can confirm GERD is by an EGD. So the hiatal hernia is a protrusion of the stomach through the esophagus. In obesity, the diaphragm pushes the hiatal hernia into the esophagus. Clinical manifestations for hiatal hernia include pyrosis or regurgitation. Management of a hiatal hernia include small, frequent meals, don't recline 1 hour after eating, remain sitting up. Surgical guidelines recommend a laparoscopic approach, but remember they have to remain NPO post-op until the gag reflex returns. Lifestyle management, well, we could include a low-fat diet, avoid caffeine and tobacco. We want to avoid eating or drinking 2 hours before bedtime. We could keep our head of the bed or your head above 30 degrees. Let's see, what else can we do? Avoid foods and beverages that can weaken the LES is often recommended. So these foods include chocolate, peppermints, fatty foods, coffee, and let's see what else, ETOH. And let's see, how can we manage dyspepsia? This can be prevented by drinking fluids after meals and remaining upright for 20 minutes. Gastritis. Who loves those hot Cheetos and those Takis? I think it's amazing when I see like younger kids just eating bags and bags of hot Cheetos. I went to Target one time and I'm looking through the food aisle because remember, Jay's gonna have milk or soy protein, so I have to read. I'm diligently reading labels. So a lady came up to me and said, "My goodness, why don't you let your child enjoy childhood and let him eat whatever he wants?" And I look over to her child, who is probably the same age as my child at that time, so like 1.5. And this kid's like a monster, probably 3 times the size of Jace, holding a large cherry icy. And those like not like the little baby bags of Takis, but like I guess the snack or medium size of the purple El Fuego Takis. So she can just walk away. Anyway, so gastritis is the inflammation, irritation, or erosion of the lining in the stomach. So it can occur suddenly or gradually. The impaired barrier allows hydrochloric acid and pepsin to come in contact with the gastric mucosa. So then inflammation causes the gastric mucosa to become edematous and hyperemic. Clinical symptoms include rapid onset of epigastric pain, dyspepsia, anorexia, acute erosive gastritis can result into melena or hematochezia. So let's just say the patient's symptoms do not resolve within 1 day and they have a continued loss of appetite for more than 3 days. An EGD may be needed for biopsy. Let's see, other irritants like medications include aspirin, the abuse of NSAIDs, and alcohol. The last alteration in GI that I'm going to talk about is peptic ulcer disease, PUD. So, your gastric mucosa defenses become impaired. So therefore, you can no longer protect your stomach from acid and pepsin. So basically, you're creating holes into the gut wall. There is no evidence that milk, caffeine, or spicy foods are associated with the development of peptic ulcers. So there are 3 types: gastric, duodenal, and stress. Gastric ulcers are deep in the lesser curvature of the stomach near the pylorus. So pain is at the mid-epigastric area. I'm going to write some keywords here. It's gnawing, pain that radiates to the back, happens probably after 1 hour from eating, and it's relieved by eating more. Duodenal ulcers occur in the first portion of the duodenum, and hypersecretion is usually the cause. So pain also happens in the mid-epigastric area. Also happens after a meal. Also relieved by eating. And it can wake you up at night. So these keywords I'm writing down is just to help you folks differentiate between the different types of peptic ulcer diseases, because they all end up sounding the same. So let's see, what can I find here? This can keep you up at night. Patients take relief with antacid if they have duodenal ulcers, but not with gastric ulcers. So you could recommend to your doctor if they have, or if you have a duodenal ulcer, and antacid. But the antacids will not work for the gastric ulcers. The overuse of NSAIDs block enzymes that protect the stomach and intestinal lining, and that leads to hemorrhage by hematemesis and melena. The biggest complication that leads to peritonitis is perforation. Oh, I didn't talk about stress ulcers. So, stress ulcers are acute from a medical crisis or trauma, and bleeding is the lead indicator. So you may wonder, well, why is everyone in the hospital taking Pepcid, famotidine, or some type of pantoprazole? Well, it's because when you're at the hospital, you are stressed, internally and physically. Patients who are on a ventilator must be placed on a prophylaxis due to stress ulcers. Now back to the overuse of NSAIDs. Let's see. So, H. pylori. H. pylori colonizes in the stomach and duodenum. It is an overgrowth. That leads to an infection. It's more commonly seen with duodenal ulcers. So, there is a triple treatment that is needed for H. pylori. That includes antibiotics ×2, it could be Flagyl or amoxicillin. If they can't tolerate any of those, it's clarithromycin and a PPI. If for some reason the patient needs a quadruple therapy, medications include a bismuth product to coat the stomach, tetracycline, Flagyl, and a PPI. Let me write that down. Quadruple therapy. Bismuth, a tetracycline, a Flagyl, and a PPI. Zollinger-Ellison syndrome, ZES, is extremely rare disease where stomach tumors produce way too much acid. Symptom control for ZES is pretty much high doses of Zantac, but it's usually resistant to standard medical therapy. So basically, you can manage this by diet modifications, including medications to help with over secretion and hypermotility.